Molly
Welcome
and
to
I
the
Thanks so much, everyone, for joining us today. My name is Molly McAlee-Malloy. Hopefully you can see me and hear me and see the PowerPoint. Somebody let me know if that's not going to work for you. I'm a nurse, a diabetes educator, and I've had type 1 diabetes for 25 years. I previously worked on what we now know as Control IQ at the University of Virginia Center for Diabetes Technology, and at a startup called Type 0 Technologies, which is now a Dexcom company, commercializing the algorithm, and then at Tandem Diabetes Care as a medical science liaison, launching the product. Now I join you as Vice President of Metabolic Health at Locus, and I've joined the team to expand the Locus business into the realm of diabetes devices. Locus has EMR integration with medical device technology accomplished in many other areas and platforms, so I'm adding to the list of devices diabetes. But today, I'm going to be talking to you about something that's very close to my heart. There are several abstracts and articles that have been sent to you via email and will be available after this for you to reference or gather more information from our two extraordinary panelists. But today we're going to be talking about device equity. I want to level set and give a quick definition of the difference between equity and equality, as I find they often get used interchangeably and they're really not the same. So equality means each individual or group of people is given the same resources or opportunities. Equity recognizes that each person has a different circumstance and allocates the exact resource and opportunity needed to reach an equal outcome. So we're talking about how to get everybody equity in device access in diabetes. Our first guest I'd like to introduce is Dr. Julia Blanchette. She's an assistant professor of medicine at Case Western Reserve University. She's a nurse scientist lead, the program director for the diabetes care and research working in University Hospital Diabetes and Metabolic Care Center. And Dr. Blanchette has provided a tremendous amount of support and advocacy for device equity as accommodations for those with different abilities to use the devices. Dr. Blanchette's paper on equity in the provision of diabetes self-management education and support will be discussed today. And again, a link will be available in the chat, will be sent afterwards to participants who did not receive it ahead of time. Our next speaker will be Dr. Brynn Marks. She is an attending physician of endocrinology and diabetes and the director of the Diabetes Center at the Children's Hospital of Philadelphia. Dr. Marks has done tremendous work on promoting access to diabetes and technology in underserved populations. And today we'll be discussing several of her abstracts and publications focusing on closed-loop and hybrid closed-loop technology and marginalized communities with significant improvements to quality of life, emotional distress, and clinical outcomes. As a reminder, links will be in the chat and we will email them afterwards if you're having trouble accessing. Quick agenda, we're going to give each speaker 15 minutes. Julia Blanchette first, then Brynn Marks. We're going to have 15 to 20 minutes of questions and answers. I would love for you to be able to type your questions in the Q&A portion of the tab above in the Zoom link. And I will be monitoring those. We will be answering them at the end. But if you have a question while we are talking, please do enter it before you forget. And with no further ado, I would like to bring on Dr. Brynn Marks.
Thank you so much, Molly, and to the whole Locus team, really, for giving us this platform to talk about such an important topic. And honestly, to Molly for securing me some of the funding that I needed to do this work. Before we jump into some of the work on equity, I wanted to start off by just thinking about the current state of type 1 diabetes here in the United States. So we have about 1.45 million people living with type 1 in the US. And the data that we have trying to best capture the population comes to us from the Type 1 Diabetes Exchange. They have about 50,000 people in their most recent data. So it's a wonderful number, but really only about 3% of the people in the US with type 1. So keep in mind that this may not actually represent everyone in the United States. But that said, there's some really wonderful literature here. And when we think about it, starting with A1C across the lifespan, so the reddish orange figure here, the line sort of showing mean A1C across the lifespan, you can see that we are not hitting the ADA recommended A1C target of 7% or less. And when you compare 2010 to 2012 in the orange with the 2016 to 2018 data in the light blue, you see that glycemic control actually deteriorated over time, and that's despite advancing technologies. And when we look at the more recent literature, Molly, if you could advance for me. Thank you. Oh, back one, sorry. Thank you, thank you. So when we look more recently at 2021 to 2022, and the figure on the right there shown in the blue, we can actually see that things have gotten better from 2016 to 2017, but still not at our goals. Next slide, please. And when we think about improving A1Cs, I think a huge part of that conversation needs to be access to technology. So when we look in the exchange data and we see who is using CGM, when we compare data from 2016 on the left to 2022 on the right, specifically here focusing on CGM, you'll see that in 2016, about 30% of the population was using CGM. Now its number is closer to 80%, which is a huge improvement. But that's not to say that we don't need to do more work to get access for that remaining 20%. The other thing I want to draw your attention to here are real differences in access according to race and ethnicity. So that yellow trend line is the non-Hispanic white population, the orange trend line is the Hispanic population, and the blue is the non-Hispanic Black population. And you'll see more than a 20% difference in rates of access for CGM, with lower rates of use in the Black population. And what about pump use? You'll see that over time, we've gone from about 50% use to 60% use most recently. But here you see even more radical disparities in access according to race and ethnicity. And then last, but certainly not least, something we're going to focus more on in just a minute is access to the hybrid closed loop systems that use CGM data to automatically increase or decrease delivery in an effort to optimize glycemic control. You see really rapid uptake since the FDA first approved these devices in 2016. But again, really radical disparities in access. So about a third of the population is using these overall, closer to 35% of the non-Hispanic white population, but here only about 15% of the non-Hispanic Black population. Next slide, please. And with that, I was really inspired to see what we could do to support better access to these technologies. So with funding from Tandem and from Dexcom, went on to design a pilot study trying to get data on access to these devices in the group that's been historically least likely. So our inclusion criteria, we accepted kids from 6 to less than 21, wanted to focus on a pediatric population for which the Control-IQ HCL system was FDA approved for at that time. We wanted kids who had sustained hyperglycemia. So at enrollment, they had an A1C over 10, and they had a second A1C over 10 in the year preceding enrollment. We specifically recruited non-Hispanic Black publicly insured youth. And the reason for that was because when we look at the literature, as we just saw, this is the group that's least likely to access the technology. Everyone participating in the study was insulin pump naive. And we took kids with up to 2 episodes of DKA in the 6 months before enrollment. In terms of the group that we did actually enroll, we had a median age of 14. The age span from 7 up to 20. 8 of our participants were over 15 years of age. So really the group that struggles most with glycemic control when we look at the population level data. About an even distribution between males and females. Median type 1 duration was about 8 years. And at enrollment, just 5 of the 15 kids had CGM use with at least 70% wear time. 6 were completely CGM naive, 4 were using it, but less than 70% wear time. And then thinking about barriers to care, 7 of these youth came from single parent households. Others identified transportation and lack of paid time off from work as barriers to accessing diabetes education. Next slide, please. And so at baseline, when we enrolled these 15 participants, time in range was only 12%. Keep in mind the recommended target is 70% time in range. So instead of spending that much time in range, about 70% of time for these youth was spent with glycemic control above 250 milligrams per deciliter. So in terms of education, we provided 2 heavy educational visits, one more focused on CGM, the other more focused on pump, and then really followed standard of care in following these participants over 6 months of HCL use. We had radical improvements. The baseline A1C went from 11.7% down to 9% at 3 months, with sustained improvement at 6 months. Time in range went from 12% to 43%, keeping in mind that in randomized controlled trials, really seeking FDA approval for these devices, you see about a 10% improvement. And that's because it's people who have more optimal glycemic control who are enrolled in these trials. Time above 250 went from about 70% down to 30. And we need better data on the implications of that in preventing long-term complications. Now, how did we get there? What was the interaction like with these systems? Median number of boluses per day was 10, which is a huge number when you compare this to other literature. And in thinking about the Control-IQ system, what you need to remember is that you can have both user-initiated boluses to cover carbohydrates or correct for hyperglycemia, or hourly, you can get a system-initiated bolus if the sensor glucose is predicted to exceed 180. So 70% of these boluses were coming from the system. And what this says to me, we didn't radically change behaviors. We just gave people access to a technology that was going to make diabetes management easier. Next slide, please. The other thing that I was so attentive to was DKA potentially as a barrier to access to HCL. Some of these kids had been told that because they'd had DKA, they couldn't use the system. Certainly other clinicians think that that's a reason not to start HCL. And so we looked carefully at this. In the 6 months before enrollment, 5 of our 15 participants had an episode of DKA. And when you calculate the rate out, that's a total of 67 episodes of DKA per 100 person years. Now contrast this with large multi-center European registry data, where in pump users, there's about 4 episodes of DKA per 100 person years. So really radically higher event rates. Now, during the 6 months of the study, 1 participant had an episode of DKA after enrolling, but before they actually started on the pump. And then we had a total of 5 episodes of DKA in 4 participants during pump use, 3 of whom had had DKA in the 6 months before enrollment. So the event rates went from 67 to 72 events per 100 person years. It was a non-significant increase, although we were radically underpowered to look for this. We would have needed closer to 300 participants to really be powered to assess for changes in DKA. Next, please. Now, beyond changes in glycemic control, we also wanted to look at changes in experiences. So we went to person-reported outcome measures. We assessed these in both parents and in youth who participated in the study. The first one we looked at was TITLE, or Type 1 Diabetes in Life. This is an assessment of diabetes-specific quality of life, and scores range from 0 to 100, with higher scores reflecting greater diabetes-specific quality of life. Now, from baseline to the 6 months at the end of the study, we saw improvements in TITLE scores in both the parents and in the youth. The second measure that we looked at was PAID, or problem areas in diabetes. That really gets a sense of diabetes distress. And here, higher scores reflect greater levels of diabetes distress. We saw significant decreases in diabetes distress in both the parents and the youth. And then the final measure that we looked at is something called the Diabetes Management Questionnaire that really looks at how engaged is someone with their diabetes management and the day-to-day tasks. Here, we actually didn't see improvements. And to me, when you couple this with the data about bolusing, this says that we didn't radically change behaviors by giving people access to these devices, but we improved control despite that. Next slide, please. And as important as the glycemic data and the person-reported outcomes data are, we couldn't help but take the chance to interview these participants. This is a really unique group of people who had been told by their clinicians they couldn't access these systems, and then they got access. And so we looked for several themes that came out of our conversations with them. The first was this idea that using AID or HCL systems provided youth and families with a new outlook on living with diabetes. And I think the best way to share this with you is really some of the quotes that we heard from participants that got us to this theme. So the mother of a 13-year-old who'd had type 1 for 3 years, she said, quote, "I felt like I got a new child that day. I can breathe." And keep in mind, this was in the George Floyd era in our country. We had another participant, a 13-year-old boy who'd had type 1 for 8 years. He said that before the pump, quote, "I didn't feel good. I would just sleep through every class. And now when I have my pump, it's making my sugar, steady. And that makes me want to do stuff because I feel normal." And last but not least, the parent of an 18-year-old who'd had type 1 for 13 years, who said, quote, "Watching her flourish, be more confident, make more peace." I would say that having diabetes, with having diabetes, it was great. And then second theme that came out of this, really from the participants themselves, is the idea that technology is most helpful for those who are struggling the most. And here I have a quote for you from a 19-year-old who said it better than I ever could. He said, quote, "You can promote it to the good people, but go into the people like me first. That's not really doing that good, and explaining it to them how y'all explained it to me in such a simple way so everyone can understand. He said that was what convinced him to use it, and the simplicity of it was why he kept going. Next slide, please. The other thing that came out of these conversations was this idea of barriers and facilitators to access. And I have to give a huge thank you to Nicole Alicia Treyes, who was a summer student with our team, who put this figure together for us, really just highlighting the clear link between barriers and facilitators here. So when we think about barriers, the healthcare team was seen as a huge barrier to access. And one of our participants said, quote, "It wasn't spoken about, talked about, like at any of my appointments, because they were just so worried about my A1C going down. And they had to keep increasing my medicines because my blood sugars just kept going up. So it felt like there was just a lack of, not offering more options." So as a barrier to that was the idea that we need to overcome implicit bias, that we need to make sure that everyone is getting access and education about HCL. And what one of the participants told us was, quote, "You convinced me to use HCL because someone actually talked to me and told me what it was about. Just say this, it will make your life easier." And that's something that's really stuck to me when I'm talking to families about these technologies and about the benefits. Now, the other theme that came out, two of us on the research team do live with type 1 diabetes, and we heard from the participants how tremendously helpful it was to hear from someone that had the experience of using these systems. And that was despite the fact that both of us on the team with type 1 identify as white. And the other thing that we heard from families as we really work to support awareness of these systems is that we need to get more support from people who look like these families, people who have a similar lived experience. Something that can hopefully help to overcome misconceptions. One of our mothers was concerned that we were going to turn her 8-year-old son into a robot with this system. We had another family that thought having HCL applied meant a surgical procedure to do that. And so really thinking about that as an opportunity. And then last but not least is this idea of social determinants of health. And one of our participants said it better than I ever could. They said, quote, "Some people deal with so many different things. Sometimes diabetes technology might be a thought." And so we need to be cognizant of that. We need to support this idea of health equity, not just equality, and making sure that people have additional resources to support their access. Next slide, please. And with that, I have to thank my research team, particularly Amanda Perkins, who has been my partner in crime for finishing up this study. And beyond that, our participants who really trusted in us, who worked so closely with us to get this data out. And with that, I am excited to hear more from Julia about access for people with different abilities. Thanks.
Thank you so much. Thank you so much for having me, Molly. I'm so excited to be here today. So first, I'm going to start by just talking about the state of diabetes self-management education and support, or DSMES. So every few years, the national standards for DSMES are reviewed and revised by a group of interdisciplinary stakeholders. And in 2022, which was the last time they were revised, there were some pretty significant updates. And the most important update is that there was a call out to provide individualized, person-centered services that address social determinants of health and technology. And so ADCES is the organization that represents the profession of diabetes care and education specialists, and they advocated for this, and they continue to advocate for this in addressing health equality to ensure all people have access to DSME that need it, but also we advocate to make sure that technology is not just equitable, or sorry, it's not just equal, but it's also equitable. And so you can see here on the right, this is the figure that came out of these revised standards. And so in the middle is this person-centered care. And around it, you can see that we should be integrating the social determinants of health, health equity, and technology. We should be addressing all of these with person-centered care. And that same year that these updated standards came out in 2022, I was invited to discuss how to make DSMES, or diabetes self-management education and support, accessible to different populations that often experience health inequities and barriers to diabetes care. So we talked about people with disabilities. We talked about people of racial and ethnic diversity, the LGBTQ community, among some other groups of individuals. And one of the key gaps that I'd like to highlight to begin with, though, is that not a lot of people receive diabetes education, like in general, despite its known positive impacts on clinical outcomes and quality of life. So we already don't, we already don't get enough people into diabetes education. And then when you have people with disabilities or of these historically marginalized communities, they have even lower rates of diabetes education, despite us knowing how much it can really benefit people and benefit people that have additional barriers to diabetes outcomes. So it's just really important that we address this as a whole. Next slide, please. So in this paper, instead of just kind of calling out all of these equity gaps that we know exist, we tried to provide some realistic ways to tailor education and support to these different populations. So one of the topics we highlighted is how to provide support to people with diabetes with lower health literacy or just lower literacy in general. And some of this is just applying what we know already works in education and health education to the diabetes setting and to the diabetes technology education setting. So for example, in this table here, we simply adapted patient communication techniques for lower literacy to the diabetes education setting. Some key highlights are using patient-centered communication, asking individuals what they already know instead of assuming, and figuring out together what they need to do to meet their goals, not assuming. Again, being aware of your bias. Using clear, slow communication, concise and to the point with as few points as possible, and really focusing in on what is key to help this individual, using plain language as well. And then confirming understanding with the teach back method is something we do a lot as diabetes care and education specialists, and it's really important when working with individuals with lower literacy. And then inviting care partners or support partners to come to diabetes education, and instead of not inviting them. And sometimes, like, during COVID, we had to call a lot of care partners in, and that's okay, or FaceTime them in, that's okay. Just however works to support that individual to help reinforce the education provided. And then also making sure that you're providing appropriate resources. Don't provide all this text literature. I provide these beautiful MyPlate, they're not posters, but they're almost like placemats with really beautiful pictures. And I use that a lot of times for my lower literacy population, instead of providing a really text heavy pamphlet that they're not going to use, right? So making sure those resources are appropriate as well. Next slide, please. So the paper that my colleagues and I wrote is great, especially with how we can change our education for diabetes education and technology at the individual level, but we still have to acknowledge that there's systematic barriers for diabetes education and technology. So systematic barriers are the policies, practices, and procedures that result in people having unequal access or being excluded, right? So they contribute more to the inequity. And I'd like to go into some examples here with the deaf and blind populations, which, by the way, have higher prevalence of diabetes and less optimal diabetes outcomes. So it's really important that we help these populations instead of further contributing to suboptimal diabetes outcomes. So, it starts with the healthcare providers and training. We know that healthcare professionals to begin with are not exposed in clinical training to elevate people with disabilities. And that's not good. So we need to start addressing that. One study that my colleagues conducted found that nearly a third of people with diabetes who are blind expressed that their healthcare providers knew a lot about diabetes, but they didn't understand how to help a blind individual with diabetes in a way that was supportive and relevant for what they do on a daily basis. And beyond diabetes devices and education not being accessible for people who are blind may also face same types of diabetes distress as the diabetes population in general. Like, they may experience some insurance distress or financial distress, or even glucose monitoring distress. But my colleagues found that the solutions are not the same, even though the distress may be similar. And so that's where more provider education really needs to come in, so we can understand how to help these populations instead of further separating them. Next, if anyone from the FDA is listening here, there's systematic barriers from the FDA. So the FDA actually has language for the devices they approve that further contributes to inequities for people who have disabilities. All of the current automated insulin delivery systems that are commercially approved, for example, have some type of contraindication or warning language that people who cannot see or hear the alarms should not be using these systems. And although that may be a safety thing from the FDA's end, it's further contributing to these people not getting access to them, despite them having accessibility tools like an iPhone, for example, that integrates with some of these devices. And you can use the iPhone to give that person the alerts that they need in a way that's accessible to them. So I know it's a safety thing, but it's further contributing to inequity, and then we can't provide patients with what they need to help set them up for success. And then lastly, devices and diabetes education have not been built in a way to help people with disabilities. For example, my mentor, Dr. Michelle Lichman from the University of Utah, she does a lot of work with really figuring out how to make diabetes education work for people who are deaf and hard of hearing. And right now it's not designed for people who are deaf or hard of hearing. For example, I can provide a certified interpreter for an insulin pump training, but there's no signs in ASL for continuous glucose monitor or insulin pump. So even though we can provide somebody to translate, it doesn't mean that the way the training is set up is necessarily set up for somebody who communicates in ASL. It's set up for somebody who communicates in English, and this adds an additional barrier. Okay, next slide, please. And so I'm not going to go into this too much, but general disparities across the lifespan, Dr. Marks addressed this quite a bit already, especially in children and young adults. But I'd just like to point out that these racial and ethnic disparities in insulin pump and continuous glucose monitors continue into adulthood, and socioeconomic status doesn't always explain these disparities. So when you're looking at the Medicare population, for example, those that are racially or ethnically diverse have much lower usage rates of technology than those who are white. And we've known for a while that socioeconomic status alone doesn't explain this, despite increased coverage for these devices. And that leads to provider bias. Again, Dr. Marks already went into this, but there is racial provider bias in discussing and recommending these devices. And we need to make sure that we are doing something to acknowledge that and stop it where it is. There's also insurance mediated provider bias. And again, we need to do what we need to do to make sure that everyone is offered technology that can help them. So instead of not discussing it because of an assumption you're making, why not explain it in a way that works for that individual so that we can help them and help their diabetes management instead of creating more barriers? All right, next slide. And so I'm going to end here with this. So based on some of my clinical observations working with a lot of young adults and adults on Medicaid in the state of Ohio, which by the way, in Ohio, the state of Ohio, Medicaid does cover continuous glucose monitoring for anyone with a diabetes diagnosis. So there's no insulin requirements or diagnosis type requirements. And I observed clinically that it was really well adopted when offered to these individuals. And that kind of led me to ask some more questions. So I did conduct some focus groups here, which I'll tell you a little bit about. The focus groups I conducted were specific to the type of diabetes. We had one with pre-diabetes and newly diagnosed type 2 diabetes, one with type 2. We had some with type 1. But here I really just want to highlight that people want access to diabetes technology. People who are offered it have, like, for the most part, across socioeconomic statuses in my population, across insurance statuses, across race or ethnicity, they want technology. And when they use it, they find it useful. And we have to really make sure that we're not creating more barriers here. And we really need to be asking people what they want. And when we're designing education around diabetes technology, when we're designing the technology, we need to be including people's voices. We need to ask them what they want and how we can create it in a way that'll help them, instead of just giving them something that already exists and trying to adopt it. And so I will leave by saying people want technology, people benefit from it across disabilities, across insurance types, across diabetes diagnosis, and we need to now figure out how to make sure that it works for those individuals. So.
Thank you so much. I'm going to stop sharing my screen so that I can answer your questions. and ask for Dr. Marks and Dr. Blanchette to stay on. That was great. I appreciate it. I have probably 1,000 questions that I could ask right now. One of the ones that came in from our listeners today was, can we discuss a little bit about the 15% or so of people with diabetes that are over the age of 50, and their sort of use of device technology phobia, if you will. So how do you address the idea of phobia of technology or fear of devices with the over 50 population? And this is a question for you, Dr. Blanchette.
Yes, so I do this all the time. This is like whenever I'm doing diabetes education, I feel like this happens a lot. So people come in, especially people that have had diabetes for a long time, may be really used to doing something one way. And so I think when you're used to something, you're comfortable with something, on top of not being, people that are older age, they're not technology native population. And so a lot of the people that I work with, they don't know how to go to the app store and download a diabetes app. And so some of it is me just sitting there with them, making it not scary, saying, hey, let's see if you have this app. And they're like, I've never downloaded an app. And I'm like, let's do it together. And so some of it is really just breaking down and getting them to download the app, showing them they can download the app, and then taking it step by step. I think acknowledging that it is scary. It's really scary when you're not used to using these devices, and when you don't know how to use the app store, like that to me is that would be really scary if I didn't know what I was downloading and I didn't know how to get back into the CGM app to see my glucose. And so really just acknowledging it, breaking it down, being patient, and not forcing it but offering it, I think is really the tactic that I use. But again, I think we need to really ask these people, like, what do you want from technology? How could it actually help you? I think that's something we're missing out on. So
that is so great. And Dr. Marks, I want to direct that question to you a little bit differently. In dealing with marginalized populations who haven't been offered the education or the resources or the technology, assuming that there might be some hesitation to use technology, or some, like you said in one of your focus groups, that a parent thought their child might become a robot. How are you addressing this and breaking that down? Because people will use the technology and they do quite well on it.
Absolutely. And I think to add to Dr. Blanchette's point, one of the things that we heard from our participants was this idea that a trial was so comforting, knowing that you could start something and if you didn't like it, you could stop. That was just huge relief to people. So just letting them know, get started. We did not have many people that wanted to stop once they were started, but I think just overcoming that barrier and recognizing they're not committed to it. The other thing we heard a lot about was this idea of peer support. Someone who is your own age, who looks like you, who can tell you from their lived experience what it was like using the technology. Personally, as someone with type 1 who is covered in all the technology, the CGM and the pump, I love nothing more than walking into a room, not telling someone that, and then we start talking about the technology and I'm like, oh, by the way, there is a pump on me. Because in the pediatric group, we hear so much fear about people looking at you and knowing that you're going to have diabetes right away. So just helping people to realize that they can disclose as much as they want, or they can put the devices in a more private place and not have to share with everyone.
Yeah. Oh, I love that. I love that. I want to get quickly into something for both of you to answer. And Dr. Blanchette, thank you so much for bringing this up. But the FDA systematic barriers on devices, this sort of medical device requirement that if you can't hear an alarm, you shouldn't be able to use a device. If you can't see something, you shouldn't be able to do this. How can we get over this? I understand from a liability perspective, being from a medical device technology background, that you have to establish, limitations of what you can and cannot be liable for, et cetera, and all this legal jargon. But the fact of the matter is we have to be able to develop for these populations, right? Particularly since they're so, they have a higher incidence of diabetes. How would you recommend we do this? Is this something where you have like, hey, FDA, let's have a talk about this? What do you think is a good idea, or how could we approach this as a community?
Yeah, I mean, I've been thinking for the past year since I started noticing this, right? Since all of these new systems started coming out and I started noticing that they all had language that somehow pointed to, people who can't hear or can't see shouldn't use this. I've been thinking, so I'd love to have a conversation with the FDA about how we can make this better. I don't know how to do that, but that would be awesome. I think part of it though is, as people with diabetes and as people that care for others with diabetes, acknowledging that this isn't okay and then coming together in a way to have these constructive conversations, also including the people that are blind or hard of hearing or deaf in these conversations is really important. They're going to use the devices anyways if they have a really good person advocating for them. But that doesn't mean that it's okay. And it doesn't mean that everyone who should be offered these devices are being offered them, right? So.
Dr. Marks, do you have anything to add?
Oh, I think a little bit of a different population on the pediatric side, but certainly I think as clinicians, we do have a responsibility to advocate for our patients, to think about when it is reasonable to use things off-label. Certainly, we do that all the time with concentrated insulins as we see these devices getting smaller and need to think about it. So being able to inform your patients about what's available and support them to get what they need from these technologies. And I will second Dr. Blanchette. If she can get a seat at the FDA table, I'm happy to come.
Well, I think part of it too, and I'm sorry I left this out, but we know that people are using these safely, right? So we know that people figure out a way to get their alerts and alarms. And maybe it's not the way that the device was FDA approved for, but they're doing it and they're doing it safely. And so I think that's something that I just really wanted to hammer in there. So
that's a very, very, very valid point. I'll see what I can do to get that conversation going in a future date. Put it on my wish list of things to do. One of the things about automated insulin delivery systems is that they really reduce the burden of management, sort of that like every minute to minute decision making that you need for optimal diabetes management. In no other disease state do we ask this much of a person, right, to do the constant monitoring. What can we do to expand access to AID, get that as an accepted first step in newly diagnosed patients? How can we approach this? There's a caveat to this in that I'll step on my soapbox for a minute, that sometimes I hear this from pediatric endocrinologists largely, that people need to earn their devices, or they need to have a certain A1C to achieve a pump or to get a CGM. And after the smoke clears from my ears, I really have to say, do you also make your other patients earn their therapies? Do you make cancer patients earn chemo, right? Do kidney failure patients have to earn dialysis? At what point are we withholding tools that are really fabulous for people because we feel like they need to earn them?
Such an important point, Molly. I think still something that I hear entirely too commonly. We've seen a shift in guidelines. So the latest ADA 2024 guidelines have recommended access to AID for anyone. I think that's a huge help. I think the other thing, it may not always be malicious that people are concerned about giving access to technology, but if you have someone who may not notice when a cannula falls out from an HCL system, recognizing that they may be more prone to develop DKA more quickly than someone who's on a 24-hour long-acting insulin, that is part of it. But at the same time, with proper education, we can do that. I think setting meaningful alerts and alarms on pumps. You do not need to know when you're over 180. You just don't. You need to know when you need to check for ketones. You need to set alerts that are actionable, that are actually going to cue people to do things, to look at their systems, to make sure everything's functioning properly. And the other thing we found with our study was we had an excellent rapport with these families. I had a few 6 a.m. phone calls. I forgot to charge my pump. It's totally off. And I think some of that we heard in our interviews with the families was that they knew that when they called us, they weren't going to be judged. We were not there to yell at them. We weren't there to chastise them. We were to say, here's a problem. This is how we solve it. And you know what? We got some of those phone calls early on. We didn't get them later. People learn from those experiences. And I think helping people to learn how to make the technology work for them is so important. And then I would also advocate for a larger study. I think we need bigger studies that are actually powered to see, are there higher rates of DKA in people who have suboptimal A1Cs? It's something I don't know the answer to, but I think it's an important question that we'll argue with clinicians who are so rooted in that idea.
Mm-hmm. Yeah. Dr. Blanchette, do you have anything to add?
I'm trying to think of what to even add to that. I think the biggest thing, though, my argument is that people who don't have high A1Cs can randomly go into DKA too from pump usage. And I see that, I do a lot of pump starts, right? And I work with a lot of adults who may be on a pump for the first time who have, in range A1Cs, and then they have a site that fails and they have ketones for like the first time ever, right? Or they they have COVID and they have, larger ketones for the first time ever. So I think it really is just focusing in on like making sure they understand the safety around it. I find that when I explain everything, at least with adults, I know kids is a little different population, different family dynamics sometimes. But at least with, when you explain everything, people understand if there's a safety risk. And usually people are willing to respond to those meaningful alerts and alarms to prevent a safety risk. The only thing that I'll add to what Dr. Mark said is another thing I do sometimes too is figuring out like there's different types of infusion sets that may be, that may work better. Like the steel ones, for example, don't kink as easily for somebody that may not be as good at assessing their site or figuring out some of those kinds of tactics to help that individual is another thing that we do sometimes too. So
yeah, I'm a huge fan of steel sets myself for that reason with 25 years of scar tissue. So
same actually, same. So.
Yeah, huge fan. So talk to me a little bit about these social determinants of health and how we might be missing some of the population. I want to say this in an intelligent way, but people on Medicaid and Medicare have CGM coverage, right? For instance, and if you have type 1 diabetes, you have pump coverage, right? So how are we missing such large swaths of these populations? I think in the T1D exchange data, the 2022 data, like the difference between A1Cs is almost a full point on private versus public insurance because they're not being utilized, the uptick, they're not being recommended as much. How can we change this approach for clinicians?
I think some of that is just rooted in different approaches to life, in different priorities for people. The quote that I shared from my participant about people they don't have the capacity to think about diabetes technology because they're worried about putting food on the table. And when I think about it in a clinical context, patients that are wealthier, people who have higher levels of education, they come into clinic advocating for themselves. They know they want these technologies and these devices. And I think to me, that speaks to the importance of us as clinicians, making sure that if people aren't asking for it, that we are telling them about it, that they know what's out there and the things they can access. And then you think about systematic factors. How do people access these? There's the durable medical equipment route. There is the pharmacy route. Adding on different places, different authorizations that are needed, different barriers beyond just simply writing the prescription. And the other thing we heard from our families in the study was access to supplies. Kids are rough. Sensors do not last the full 10 to 15 days that they are supposed to. They come off, they lose infusion sets playing in football games. And one of the very simple things we did, we gave people extra supplies. It wasn't the end of the world when things fell off. So I think there are both sort of individual level things that we can do, and then also systematic things that need to be done just to make things as least stressful as they can be.
Yeah. And I think to add on to that, just making sure you're offering support. I think, with the Medicaid population, I was really fortunate to be we were fortunate to offer to our healthcare system a group of patients that were on Ohio Medicaid. Actually, we reached out to them and we offered to start CGM with them in person. And we helped them get their first CGM. We didn't necessarily provide it for them, but our healthcare system has a pharmacy that takes a lot of the Ohio Medicaid plans. And so we could get them their CGM that day. We could start it together. And so helping them access it, but then also like actually training them through it, following up with them, we found to really help. So I think some of it is, they are worried about a lot of other things in their life. They're worried about safety. They're worried about access to food. They're worried about, transportation to work. And those things are on their mind constantly. But if we reach out more and we offer our support more, and build relationships with them to do so, I think that is part of it, what we need to do better. So
I love that. I love that. Do either of you have additional thoughts you want to share or challenges you want to give the community at this time? No, you're not going to challenge anybody. I'm going to challenge myself included that the next one of these webinars that we have ASL offered in the corner there. So I know we have closed captioned and I've tried that before. I don't know if it's I just don't speak well enough, but oftentimes it ends up being garbled. So I don't know how helpful that is, but I will challenge myself to do that in future webinars so that we can be more accessible. I love that you mentioned Michelle Lichman and all of her work that she does there, but she has inspired me to start learning ASL.
Me too, actually. So there we
yeah.
go. Yeah.
I'm not on the spot yet, but when I get better, I appreciate it. I will absolutely do that for you.
Awesome.
Well, good. I appreciate everybody's time today. We're going to email out some resources. If you have further questions, you can always reach me at molly@locushealth.com. And we will be hosting these regularly. Please tune in. Feel free to suggest topics, ideas, things that we can talk about to raise awareness in the community. I want to thank again Dr. Blanchette, Dr. Marks for your time and your commitment to advocacy for equity in diabetes devices. And thank Locus Health for supporting this webinar and raising awareness. I will give everybody a few minutes back for your lunch, and I hope you've enjoyed this, and we look forward to talking with you again soon. Thank you, everyone.
Thank you.
Thanks.